Hello and welcome to a Health Podyssey. I'm your host, Alan Weil. Medicare Part D plans, which cover prescription drugs, compete in part on how effectively they negotiate prices for the drugs they cover, which in the arcane world of drug pricing really means how large the rebates are for those drugs. But under the Medicare statute, there are 6 protected classes where all drugs in that class must be covered. The inability to exclude a drug, one might expect, would affect the rebate negotiations. So how do rebates for protected class drugs compare to rebates for other drugs? That's the topic of today's episode of A Health Podyssey. I'm here with Pragya Kakani, Assistant Professor of Population Health Sciences at Weill Cornell Medical College. Kakani and co-authors published a paper in the October 2024 issue of Health Affairs that examines how the protected class status of drugs affects their rebates. We'll discuss what they found in today's episode. Dr. Kakani, welcome to the program.
Thank you so much for having me.
Well, just to set the stage here, I think most people are familiar with Medicare Part D, and we just had the government negotiating some prices, but this is a different provision of Part D. We have what are called protected classes. If you could just explain to our listeners, what does it mean for a drug to be in a protected class, and why do we even have them in the first place?
Yeah, absolutely. So thank you again for having me. Very excited to talk about this topic. So as you mentioned in your introduction, the Part D benefit is provided by private insurers, and the government generally gives them some leeway in how they design their plans, including what drugs are going to be covered. But for 6 protected categories of drugs, which are referred to as the protected classes, Medicare Part D plans are essentially, with very limited exceptions, not allowed to exclude any drugs from coverage. And, these 6 categories are not trivial. They account for almost a quarter of spending in Medicare Part D, and they include medications for cancer, HIV, epilepsy, depression, psychosis, and a limited number of immunosuppressants that are used in organ transplant patients. Now, in terms of why protected classes exist in Part D, I think that's a really interesting question, and there's probably multiple answers to it. But the main reason is that I think there was a general thought that the patients using these drugs are particularly vulnerable and sick. And so understandably, there was a desire to preserve access to needed medications. And I think that concern was especially pronounced for patients that may be switching from Medicaid to Medicare. And Medicaid, all drugs are covered. And so if they found that a drug was not covered in Medicare, that could lead to disruptions. I think secondarily, there was also concern that if plans could exclude these drugs, they could sort of strategically design their formularies to avoid less profitable patients, which economists call adverse selection. And so that was also a partial motivation for the policy. But, all that being said, I don't think there was a very clear formula for, how it was decided that these 6 classes in particular would be protected.
Well, I appreciate that explanation, and I like your acknowledgement that there are multiple reasons that might put something in a protected class. We're not going to go deep into what is or isn't or why they should or shouldn't be. In this conversation, we might save that for another day. But at least we have an understanding that this is a lot of drugs, very important medications. Now, just to make things even more complicated, your study focuses on rebates, and, we could have the entire discussion this afternoon solely about rebates, but I'm going to spare our listeners that. But I don't think we can really interpret your results if we don't at least have a basic understanding of how rebates function, and particularly why there's a potential interaction, the hypothesis that you are testing, that there's a potential interaction between being in a protected class and the ability to negotiate a rebate.
Yeah, so I'm happy to share a little bit about how rebates work and why protected class policy might affect them. So rebates are these confidential discounts on drug prices that are negotiated behind closed doors between manufacturers and health plans, or more commonly pharmacy benefit managers that work for the health plan. And manufacturers are usually willing to give health plans discounts in exchange for some kind of preferred treatment on the formulary. And this can take multiple forms. It could be in the form of lower out-of-pocket costs on their drugs, not having prior authorization on their drugs, or it could be in the form of some adverse action against a competitor, like excluding a competitor from the formulary. And all of this, because it can drive volume to the manufacturer, is enough enticement for them to give a rebate to the health plan. And while this sounds kind of obscure and arcane, in recent years, our work and others have shown that these rebates have really grown dramatically, and often they're over 50% now. And so they're increasingly important for thinking about the drivers of prescription drug spending at the aggregate level. Now, the worry with protected class policy is that it may reduce plans' ability to negotiate these rebates, because essentially what it does is it removes plans' biggest carrot and their biggest stick in these negotiations, which is their ability to exclude drugs. So a plan can no longer threaten to exclude you, and they also can't offer to exclude your competitors in exchange for a higher rebate. So our hypothesis, and we're not the first to articulate it, but perhaps the first to formally test it, is that protected class drugs would have smaller rebates and therefore ultimately be more expensive for payers.
Okay, so the sort of basic economic theory here, you're in a negotiation and you've taken away a key source of leverage on your side of the negotiation by making it impossible to exclude the drug. And you would expect that to have some consequences. So let's start peeling back the layers of the onion of what you found. And the first instance is that the causal chain that you're describing begins with it being less likely that the drug is excluded. And then if it's less likely that it's excluded, that would potentially affect price. So let's do the first part of that first. What did you find in your looking at the data regarding exclusion of protected class drugs from formularies relative to the ability to exclude drugs when you're not in a protected class?
Right. So as you noted, the first thing we wanted to check was whether Medicare's protected class policy actually seems to make a difference to Medicare formularies and what they look like. And we felt that checking this was an important first step in terms of thinking about the impact of the policy, because you could imagine a world where Medicare plans just can't get away with excluding any drugs if they want to be competitive. So even though this policy exists, it doesn't make much of a difference. You could also imagine a world where maybe they can get away with excluding non-protected classes, but protected classes are so different in the nature of competition and how substitutable they are that they really couldn't get away with excluding those anyway. And so what we did is we compared average exclusion rates between protected and non-protected class drugs in Medicare as well as in commercial plans where there is no protected class policy between 2011 and 2019. And I think our results showed a few key things. The first is that, indeed, protected classes are far less likely to be excluded than non-protected classes in Medicare. But perhaps more interestingly, this difference in the exclusion rate is much smaller in commercial insurance. And moreover, the absolute rate of exclusion of protected class drugs was higher and non-zero in commercial relative to Medicare. So this idea that protected class drugs just could never be excluded doesn't seem to really hold up. So taken together, I think these set of facts is consistent with the idea that this policy really does make a difference to Medicare plans' ability to exclude protected class drugs.
Okay, so I just, this is complicated and I'm trying to follow. I think I did, but I want to just say it back to you and see if I get this right. So in the first instance, you have this Medicare provision and the answer is they're adhering to it. But you need something to compare it to. And so you're taking the commercial market where you don't have protected classes, and you really do see different behavior over there. And that even drugs that are in what Medicare considers a protected class do get excluded from formularies in the commercial side, which means it is possible to have a competitive market over there to exercise leverage by excluding. And that leverage has been taken away on the Medicare side. Is that kind of what the picture is?
Yeah, that's exactly right. The commercial plans do to some degree exclude protected class drugs, and that difference between protected and non-protected class drugs is much smaller in commercial than it is in Medicare.
So given all of this, of course, I want to move to what this means in terms of rebates. But we're going to save that topic for after our short break, which we'll take now. And we're back. I'm speaking with Dr. Pragya Kakani about how Medicare Part D protected class policy affects the ability to obtain rebates on those drugs relative to drugs that are not in a protected class. Thus far, we've had a really good conversation about sort of what the market looks like and what the policies are. And what we see is the exclusion of drugs from the formulary on the Medicare side is very low for protected class drugs. So the natural conclusion would be that the rebates are smaller. And I guess let's just kick off this portion of the conversation by me asking you the question, is that what you found?
Yeah, so that is exactly right. That is our hypothesis, and we do find some evidence of that. So what we did was we compared average rebates between protected and non-protected classes each year, again from 2011 to 2019. But the key caveat here is we couldn't do exactly the same exercise that we did with exclusion rates, where we couldn't compare Medicare and commercial rebates in protected and non-protected classes, because those segment and drug-specific rebates are very closely guarded trade secrets, and so they're not generally available to researchers. So instead, we worked with what we had, which is the difference between manufacturers' ultimate take-home revenue and the list price of the drug, which is in essence sort of a U.S. level average rebate across all payers. So with that very important caveat in mind, what we found is that this U.S. level average rebate is indeed much lower in protected classes compared to non-protected classes. And this difference seems to grow over time at the same time as the number of formulary exclusions on the non-protected classes have increased. So in 2011, there were relatively small differences in rebates between the two groups, but by 2019, rebates were 25% higher in the non-protected classes than in the protected classes.
And so just to put this in context, this is a period where rebates are growing on the whole. So basically, the primary cost containment tool being used by the purchasers is rebates, and they're just not able to use that tool as effectively on protected class drugs.
Yeah, that's exactly right. The rebates are growing substantially at the same time, coincidentally or not coincidentally, that formulary exclusions have been increasing. But that trend does not seem to appear there for protected classes.
So one of the things that I found really interesting in the paper was this analysis you did looking at Medicare market share. I thought this was very clever. And so I wonder if you could describe it to our listeners and explain how you used it to basically bolster the confidence you have in your findings.
Yeah. So in this final analysis that you're referencing, what we tried to get at is whether these differences in sort of U.S. level average rebates between these two types of drugs have anything to do with Medicare, or if they're just sort of intrinsic differences between these two types of drugs. And so what we did is we stratified the drugs by the share of their sales that come from Medicare. And then we did that same comparison between protected and non-protected class drugs for the drugs that are have very limited exposure to Medicare and the drugs that have really high exposure to Medicare. And what we found was really interesting and striking, and maybe the clearest result I've ever seen in empirical work, which is the difference between rebates was really much greater for drugs with higher exposure to Medicare than it was for drugs with lower exposure to Medicare. And on top of that, these results were not exclusively related to one category of drugs, and they were robust for controlling for a number of things. And so even though we can't see the segment-specific rebates directly, I think this analysis shows that Medicare's protected class policy does seem to be associated with lower rebates, which ultimately means higher costs for taxpayers and patients.
Right. So if you had the rebate data by market share, you wouldn't have to do this analysis. But since you don't have that, think of this sort of as a proxy. Like, well, if Medicare is the dominant payer and we're seeing low rebates, then that's a phenomenon that's happening more in Medicare than in a place where Medicare isn't. I think that I agree with you. It's very dramatic, and it's a nice. If our listeners go to the article, you'll see a nice exhibit that shows that. So you now noted at the end of your answer to that last question about this is all about money being paid by taxpayers to support people's access to medication. And I want to go back to where we started when you explained the protected classes. Part of what you said was that they're there to preserve access for people with particular health vulnerabilities. You mentioned the transition from Medicaid to Medicare as a critical point. But at the end of the day, given your findings, it would be reasonable to conclude that the protected classes policy is costing the taxpayer money. The Part D plans can't negotiate as big rebates, and that money's coming from somewhere, and a good share that's coming from the taxpayer. So if you're sitting in front of a policymaker who's also hearing about how important it is to cover all of these drugs, how do you get them to understand, if you could, the trade-off between the access protections provided by having a drug in a protected class and the potential cost implications of having the same drug in the protected class?
Yeah, so that, is the $1 million question. And I think probably the most important question for future research in this area. In this first paper, we didn't do a full formal analysis comparing the costs and the benefits of protected class policy. But our goal was more to shed light on the fact that there is a real trade-off here in terms of affordability and cost, and maybe one that's bigger than people have realized. And so, while we don't do that full analysis, the cost-benefit analysis, I think our paper does suggest that policymakers might want to at least consider changes to Medicare Part D's coverage and pricing policies that might do a better job at managing costs while maintaining access in the most high-value use cases or for the most vulnerable patients. So, that could take multiple forms. It could be something incremental, like allowing exclusions in protected classes when CMS deems that there are multiple therapeutic alternatives. Or it could be something like eliminating protected classes except for patients who are dual eligible or otherwise vulnerable. Or it could be something more dramatic, like allowing Medicare to negotiate drug prices earlier in the product's life cycle than the Inflation Reduction Act allows for, so that the pricing part of the equation is not left to individual plans that don't have the leverage that the Medicare Part D program could bring as a whole. And so, while I don't have all the answers for you today about which of these policy solutions would be best, I hope this work sort of sparks a dialogue on how we balance access and cost for prescription drugs in Medicare Part D, but also beyond that.
So what's interesting to me as you answer that is that I've thought of this sort of primarily as a clinical versus economic analysis. Like, well, what are the clinical imperatives associated with having broad access to drugs in a protected class relative to how much we spend because of the limited negotiation? But your answer gives me, I don't want to exactly call it a way out, but a somewhat different way of thinking about it, which is that even purely on the economic side, we could think of policies that would recapture some of what we're losing due to the inability to negotiate rebates, even if we wanted to make no changes at all in the access the access to the drugs for people who need them. So it's not really just a dollars versus access; it's also a dollars versus dollars, or thinking about ways to restructure the payment side that aren't just because of course there'd be huge pushback if it was just about limiting access. But maybe there are ways to capture some of the dollars without limiting access.
Yeah, I think that's exactly right. There are trade-offs in terms of like clinical substitutability between drugs, and there probably are situations where even if you didn't want to rehaul how Medicare Part D priced drugs, you could potentially allow exclusions where it's not going to make a huge clinical difference. There's a second part of this of protecting vulnerable patients, and so you could have carve-outs for vulnerable patients, or you could think about ways to get the pricing lower through other mechanisms. And so I guess that is how I might think about bucketing the potential policy solutions here.
Well, that's really fascinating. Dr. Kakani, thank you for doing this work, a very clear explanation of what you've done. And the stakes here are quite high, both medically and financially. These, as you said, account for a quarter of the drugs in the program, and a lot of people depend on them for very critical health conditions. So a critical topic with some great insights. Thank you for being my guest today on A Health Podyssey.
Thank you so much for having me.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about A Health Podyssey.